All right, it is officially 7 o'clock and we will get started. I want to thank those of you who got up early on a Sunday morning in Maui to be here and appreciate your attendance. I'm Dan Dent from UT Health San Antonio.
Hi, I'm Joe Suker from Phoenix, Nonner Health System.
All right, and welcome to Quickshot Session 7. Our first presentation will be by Dr. Roach from University of North Dakota, A Call for Help, a national study of self-inflicted trauma among American Indians. Dr. Roach, the podium is yours.
Thank you very much, and thanks to Southwest Surgical for giving me this opportunity. My name is Connor Roach. I'm from UND, one of the residents, and I'm going to be presenting a call for help, a national study of self-inflicted trauma among American Indians. I have no disclosures. The CDC shows that self-inflicted injuries account for over 250,000 of ED visits, and with 20 to 50 times the risk of completion suicide after a self-inflicted injury in adolescence, it makes suicide one of the 10th most common cause of death, with around 46,000 deaths by suicide annually. The American Indian population accounts for about 2.5% of the US population and have a higher rate of suicide versus their non-American Indian counterparts at around 22 versus 14 per 100,000 people. So here I present an epidemiological study on the incidence and characteristics of self-inflicted harm in the American Indian population from the standpoint of national hospitals. We gathered data using the National Trauma Data Bank from the years 2012 to 2017 and selected patients using ICD-9 codes for self-inflicted injury. We analyzed them on categorical and continuous variables. Variables studied were basic demographics, mechanism, substance use, length of stay both in the hospital and ICU, injury type, payment, and discharge disposition. With that, we were able to identify around 78,000 patients, with over 1,100 of them being American Indians, or 1.5% of our patient population. In studying the data that we got, American Indians tended to be younger by almost 9-10 years, more female, used Medicaid as a payer more frequently, used more cutting and piercing mechanism, less firearms, more alcohol and drug use, while also having a shorter length of stay. And these were all statistically significant variables. So here, American Indians represented only about 1.5% of our patient population, yet account for 2.5% of the US population, while also having a 64% higher rate of suicide. This shows that there's lower rates of presentation with self-inflicted injury and suicide to national hospitals, which is a likely multifactorial causes, including higher completion rates, lack of access or distance from hospitals, and this leads to the less severe and shorter lengths of stay when presenting to the national hospitals. So this is a novel epidemiological study on the national hospitals reporting self-inflicted injuries in the American Indian population. Some of the limitations, causation is kind of unclear and it's likely multifactorial. We're also limited by the constraints of the data set. So with less severe injuries, more substance use, more federal healthcare assistance, we felt that this was very much a physical manifestation of a call for help in the American Indian population when presenting to these hospitals with self-inflicted injuries. This study kind of further helps characterize trauma admissions with self-inflicted harm and identifies a possible time for intervention. So what can we do about this? This can help drive some public health initiatives, increase mental health awareness, kind of shows the importance of social work consults at the time of admission, especially in this population. And it identifies also the critical need for access to care. Some of the future directions that we'd like to take this is compare data to local statistics where there's a higher density of American Indian populations, especially in the upper Midwest. And then further investigate the reason for lack of data in the National Trauma Data Bank, whether that's higher completion rate, lack of access, but just further delineate why we're not picking up those patients. I'd like to give thank you to Dr. Mehdi and Dr. Sang, UND and Sanford Health. I'm happy to take any questions at this time.
Great. Nicely presented. Feel free to make your way to the microphones for questions. My question is, there's at least one medical school in the US that specifically is trying to recruit and train American Indian physicians. The University of Minnesota branch campus at Duluth was founded just for that purpose, to help get American Indian, Native American physicians into the communities to help deal with some of the problems that are specific to those communities. Are you guys doing anything like that? Are you aware of any other efforts like that? And could that be part of our solution if we did more of that?
Oh, absolutely. The University of North Dakota participates and supports in-med students in the medical schools, which is nationally funded spots for the medical school, to try to increase the number of American Indians going back into the reservations and back to the places where they're from, to try to increase the quality of care. Also in our region, we have up in North Dakota area, we have a significant number of American Indians in the population, and they account for a good percentage of our healthcare that we provide. And so there's a lot of ongoing research that we have both on surgical and other levels, trying to address disparities in healthcare and that sort of stuff.
Yeah, well, I commend you for doing this research. Preventative research is a pillar that we stand on, but we often forget about it or don't look at it enough. And so this is very important. But it's interesting, we're doing it as surgeons in a behavioral health way. And again, I think that we should branch out, because we do touch every part of medicine, and this is one. We know in our American Indian population or Native American population that drugs and alcohol, as you point out, are a big problem. And I just wonder if these different services within within this population that's offered in the bureaus are interconnected with the drugs and alcohol bureau and the behavioral health bureau and the suicide prevention. There's a number of these areas that operate, but I don't know how connected they are. I don't know if you have insight into that area.
Not a ton in that specific area, but inside our hospital systems, it has to be a multidisciplinary approach. We take care of these patients and their medical problems, but we see patients of all different ethnicities and backgrounds, and I think being able to address them where they're from and where they're at, and getting that multidisciplinary team, social work psychologists, behavioral health specialists, all that kind of stuff, I think is really important and critical to our ability to make a change when they present in ways like this. So.
Thank you.
Yeah, thank you.
Thank you very much. Our next presenter is Dr. Bloom from University of California, Irvine, speaking about marijuana use associated with decreased mortality in trauma patients. Welcome.
Thank you. Good morning. Not quite a doctor, but I'm a second-year medical student at the University of California, Irvine School of Medicine. And as you said, I'm going to be talking about mortality as it relates to marijuana use in the trauma population. So no disclosures, no conflicts of interest. So marijuana use is a hot topic today. According to the National Survey on Drug Use and Health, an estimated 48 million Americans used marijuana in 2019, and that saw consistently upward trends over the 4 years prior to that. This trend has also been seen in the trauma population. So the top study showed that the incidence of marijuana positive trauma patients has increased among all age groups, while the bottom study showed that 50% of all adolescent trauma patients presenting to a single trauma site tested positive for marijuana. So all of this begs the question, how does marijuana use affect outcomes in these trauma patients? The current literature has been somewhat variable, with some studies suggesting that marijuana use is associated with increased risk for thromboembolic events. However, other studies have found that it was associated with decreased risk of mortality in the ICU admitted trauma patients. So based on a review of the literature, we hypothesized that a positive marijuana screen would be associated with a decreased risk of mortality, including in planned subgroups of intensive care unit admitted patients and younger adult subgroups, meaning less than or equal to 40 years old. As a secondary aim, we also sought to determine if a positive marijuana screen would be associated with a decreased risk of major complications. So we queried the 2017 Trauma Quality Improvement Program for all adult admits that year. Included in our study were patients who tested positive for marijuana or tested negative for all drugs. Excluded were patients dead on arrival, not drug tested, and those who tested positive for any drug other than marijuana. We then compared these two groups, negative drug screen to positive marijuana screen, based on the primary outcome measure of in-hospital mortality and the secondary outcome of major complications during admission, which we defined as myocardial infarction, pulmonary embolism, acute respiratory distress syndrome, unplanned return to the OR, stroke, pneumonia, and/or unplanned intubation. So we then compared these two groups using first bivariate analyses, and then a multivariable logistic regression analysis was performed in order to determine if there was the associated risk of mortality in marijuana positive patients after controlling for known predictors of mortality. And then we did a similar regression for major complications as well. So we found that marijuana positive patients were more likely to be younger and male, though these two groups had similar injury severity scores. Marijuana positive patients had a lower rate of all of the listed comorbidities except for smoking, which was higher in marijuana positive patients. And marijuana positive patients had a higher rate of tachypnea, tachycardia, and a Glasgow Coma score of 8 or less. However, they had similar rates of hypotension. And so here, after controlling for all the known predictors of mortality, which are listed here, including age, sex, etc., the adjusted risk of mortality for marijuana positive patients was lower than for negative drug screening patients. And this trend persisted in subgroup analysis of the ICU patients and the younger adult patients. However, there was no difference found in risk of major complications. So we believe that this data has significant clinical impact due to its high degree of statistical power and generalizability, and we believe it could have high potential for the treatment of trauma. However, there are some limitations, including that this was a retrospective database design and inherent limitations in marijuana screening, such as an inability to determine the pharmacokinetic factors of marijuana that could affect this data, such as frequency, dose, time since last use, and methods of ingestion. Also, THC is a surrogate marker for marijuana use in drug screening. So we're unsure if this effect is due to THC, CBD, or one of the other active compounds in marijuana. So in conclusion, a positive marijuana screen associated with decreased mortality. We would like future prospective research to confirm these findings and determine if there's any therapeutic benefit in administering marijuana post-traumatic injury. So I just want to give a special thanks to Dr. Namias and Dr. Gregorian for their continued mentorship. I want to thank UCI, School of Medicine for funding and support. And thank you all for listening this morning. Any questions?
Avi Bavaraja, University of Arkansas. I know you guys weren't really trying to answer this with a database study, but did you have any discussions internally about why you think this might be the case? Like, I mean, you don't have a firm answer, but just I'm curious about your thoughts, your hypotheses, your discussions about that.
Oh, definitely. The current literature is kind of inconclusive on this point so far, but in rodent models, it has been shown that marijuana use has been associated with a decreased inflammatory response. So I believe that if there is a causal relationship, then it could be related to the decrease in inflammation seen after trauma.
Shrapple, Colorado Springs. Do you think this is an effect of somebody that's built up a level of marijuana before their injury? So all those protective factors are already there as opposed to giving it to them after injury? And would it have the same effect?
Right. Again, I wish we had those variables such as dose and recency of use. I think that if there's a causal relationship, it's likely dose dependent.
Yeah, so when I hear this presentation and read this abstract, I think we have to either conclude that TQIP is missing some key data points that doesn't account for some of the reason why people die, or we should be giving our patients a toke in the resus room. And which of those do you think is true, I guess, is my question.
I'd say the answer probably lies somewhere in the middle of those. We need prospective research to really figure out if this is causative, but I think this is promising. We're finding a lot of different medicinal uses for marijuana. It's currently used as a medicine in 36 different states, so I don't think it's too unlikely that there is some benefit to patients.
Well, first I want to say you did an excellent job at
Thank you.
at this presentation. That's fantastic. It's an interesting topic. I have a few rules. One of them is any one thing tends not to change outcome by 25% or more. So I'm dubious as to THC or CBD or anything. We always are looking for some immune modulator that's going to stop endothelial leak. Everything from steroids to drochicogen alpha to TXA and everything in between that we've theorized. So it's interesting. We'll see. The one thing that we do know about endothelial leak and shock is that you have to administer the drug before shock happens. So maybe that has something potentially. But one question I had was how many of the patients were positive for other drugs or alcohol? I mean, did you look into that and how did that bear out in your regression analysis and adjustment factors?
I'm sorry, I don't have the number of the exclusions in my
Yeah,
mind.
because I think it's important if you're dealing with a bunch of pot smokers versus alcoholics. I'm sorry, I'm just doing that for fun. But if you have people who are smoking THC or people you're comparing against the others that were intoxicated with alcohol, I think you have two radically different patient populations. That could
Alcohol
explain.
was actually not an excluding factor. It was only illicit substances other than marijuana.
But were folks that were intoxicated with alcohol in the study?
Yes.
And so is there a disparity between those two groups that you've tested? In other words, were there more alcohol intoxicated patients in one group versus your THC group? Do you know that? That's sure. Okay. So but that really, I think, is one of the things that can really explain some of this stuff. And really, did the regression analysis really adjust for the radical difference in age? I mean, the non-THC group is twice the age of the THC group.
Right. Yeah, there were significant baseline differences in the groups, but we did control for this.
But it's thought-provoking. You did a fantastic job, I gotta say.
Okay. Thank you, sir.
Thank you.
Thank you.
All right. Next, we have Dr. Lawless presenting Place the Sheath. Empiric 7 French ephemeral arterial sheath placement for potential REBOA is safe during initial resuscitation.
Morning. Thank you for the privilege of the podium to present our work. I have no disclosures. So the REBOA gets a lot of attention in all the trauma literature. Pretty much every month there's something that comes out about indications or improvements or specificities or whatever we're doing with it next. But that very first step of the REBOA placement, the arterial sheath placement, doesn't get a lot of press, doesn't get a lot of talk. Central access in and of itself is only really promoted by ATLS. It's not really promoted by any other trauma body that we talk about, and through the American College of Surgeons, that's the only time we actually see place something in a central catheter while you're resuscitating, but nobody talks about the arteries or placing arterial sheaths. And we know the history of REBOA, every conference talks about it a little bit, but since 2014, we've really seen the increase in the use, but also the improvements in the technology down to a 7 French sheath, which is 2.3 millimeters in diameter in placement, which is still a large bore catheter. It is the rate limiting step. And we know from interventional radiology and cardiology literature that the complication rate is about 1.5 to 4%. And it's usually hemorrhage related or hematoma development related. However, it is safe, it is tried and true, it is reliable, and it is one of the ultrasound sites that we can do that's also compressible. Now at the Ernst Moore Shock Trauma Center, we started our REBOA program in 2015. We trained our own surgeons. We also sent them to the best course. And then we adopted the Primetime REBOA in 2016 as well. We published our original algorithm in 2016 and have modified it up to 2019 to include a significant number of physiologic parameters, including the blood pressures that you see above, but also the mechanisms of injury, including abdominal, pelvic, and extremity hemorrhage. And we're placing REBOA in some sort of way, shape, or fashion in all of these patients. In 2020, we took a step further and we started an algorithm for the sheath placement. If you presented with blood pressure less than 100, you got a 5 French sheath, less than 90, you got a 7 French, less than 80, you got the REBOA, or something in the middle there. And all of these actually got duplex ultrasounds after removing them. This generated a lot of talk, as you can imagine, at M&M, and as well as group discussions in the hallway, and then coming to my office and shutting the door, and talking about risk benefit. Were we actually hurting patients by placing more sheaths, and were we hurting patients by this evolution of our own algorithm? So we decided to take a look at this, hypothesizing that placing that 7 French arterial sheath under emergent trauma resuscitation conditions would actually have fewer complications than placing it and putting the REBOA in. Pretty much the REBOA would have more complications than just the sheath. We did a retrospective review of 5 years of data from January of 16 through December of 20 at our level 1 trauma center. And we looked only at urgent femoral arterial access that was recorded in the trauma registry. We excluded those patients that got the access for IR interventions or for TVARs, any hemodynamic monitoring, meaning any 18 or 20 gauge catheter. And we also threw out those original 12 French sheaths because that wasn't the current state of the REBOA. So those got thrown out as well. We divided that group into the REBOA negative and the REBOA positive group, meaning REBOA negative 7 French only. We looked at demographic and patient outcome data, as well as arterial access complication data. In total, we had 14,480 patients in the registry over those 5 years, with 234 getting a recorded arterial line in the trauma bay. We excluded 77 for the reasons that I stated, and it had 157 patients in the total group, splitting 69 into the REBOA negative and 88 into the REBOA positive. If you look over on the left side, this is the demographic data. Focus down on the bottom. The ISS was higher, as you probably would expect, in patients that had a REBOA that was placed. So that is the major difference between the two groups. And over on the right side, we did have a significant difference in all of the sheaths that were placed, where we placed them. But of note, what we really wanted to look at was that complication rate. And we found a 4% complication rate in the 7 French sheath group and a 23% complication rate in the REBOA group. So this was definitely significant as well. And here's the definitions of what we said were arterial access complications in that laundry list. So we broke this down further, looked at the number of sheaths placed compared to REBOAs. You can see that sharp increase in 2017. And this is when we first adopted that 7 French sheath and Primetime REBOA, and then it decreases over the next couple of years with changing indications and evolution of our management. And then that real stark increase in the amount of 7 French sheaths that were placed in 2020, and that was when we implemented that algorithm that I talked about. These are all significant. So we decided to look at the REBOA complications in a post hoc analysis. And you can see that our complication rate from 16 all the way down to 19 is pretty good decrease in the amount of complications that are happening. This is surgeon experience and comfort level with the amount of REBOAs, but a real stark increase in 2020. And this is when we started looking at that duplex ultrasound. And so we're seeing smaller injuries or injuries that are not clinically as significant by those ultrasound metrics. We did not see this in the 7 French sheath group. In fact, I didn't put the graph up because it was 0. Some of the limitations, it's a retrospective, it's a trauma registry review. This is tough to kind of get those out of the registry. Technology training and experience was all different between the groups as we went over time, and we implemented those algorithms as I talked about, and it's such a small sample size. So we do conclude, though, that placing a 7 French femoral arterial sheath in the urgent trauma setting is safe, and it does have a low complication rate. Well, thank you very much. I'm happy to take questions.
Eric Peltz, Kalispell, Montana. Brian, that was a great talk. So coming from my previous life as a trauma surgeon on a major academic level 1 trauma center, we placed these. And I could even say then that there was some variability in provider comfort in the initial robo experience. So I love that in the initial part of this talk, you said everybody at Denver took the best course, you trained up all your partners. So in a very trained up, high volume trauma center, your data shows that it's safe. I've now transitioned out of that level 1 center, right? I'm in a level 3 trauma center with a huge catchment area. I have blood products available. They're all thawed, ready to go. And I get about 40 patients with major blunt trauma that come in hypotensive. But my pre-hospital transports are an hour, hour and a half. How would you advise those of us not in the big academic centers? How do we make it safe? Do we all need to go take the best course? Do we train up? Do we put it in all of ours? Are we going to have the same experience, the same results that you are at arguably a very, very good academic trauma center?
Eric, thanks for the question. I think that encouragement of placing that femoral artery sheath or getting over that initial hill to put that sheath in is the big one, right? So getting people very comfortable with getting arterial access under ultrasound in the common femoral. And if we're still a little uncomfortable about it, starting with that 7 French sheath and bumping up to the 5. Granted, our data wouldn't say that actually makes any difference, but it does in a comfort level. And I think comfort level is a big deal with this. So starting with that 5 into a 7. Placing the Roboa itself, I think going to the courses is great. The Roboa company is starting to branch out into smaller centers. However, there's no good data at smaller centers or in transport on whether or not this is safe or not. I think time will tell with that and experience will tell with that. And now that the partial Roboa is coming out, there's 7 centers that are these centers of excellence. So instead of rolling this out and sending it like a shotgun approach to every trauma center out there and see what happens, they're trying to get a good idea of what is that next training that's needed. What's the algorithm we need? How do we get everybody comfortable with it? How do we make sure patients are safe? And that's coming. And we're currently taking part in that, but it's going to be a little bit of time before that comes. Thanks.
Ryan, great talk. Did you give them a chance at all to have resuscitation, or was it just their index blood pressure? Because nearly half your patients didn't need it in one complication, and half your patients that didn't need it might be too many. And then why did you vary from the company's recommendation of just using an 18 gauge arterial line, which probably has lower complications than the 7 French sheath?
Tom, that's a good question. So that sheath conversion rate, I'm trying to coin this term now, the sheath conversion rate. I don't know if that's going to mean anything. And one of the reasons that I wanted to look at this, but if your sheath conversion rate is getting smaller and you're just putting a bunch of 7 French sheaths in patients, are you truly hurting them? That's what we tried to answer. Now, half of them not needing it, are we wasting time and giving resuscitation? We kind of do it at the same time. And we were going off that initial blood pressure, but I personally have abandoned putting the sheath in, starting a unit of whole blood, starting to get everything in while the top of the bed is doing the initial primary resuscitation, then abandon and say, okay, our next blood pressure is 100. Let's slow down a little bit, and the heart rate's coming down. So is it that we put in this algorithm and we're beating it to death? Probably. And we'll see into next year and the year after as we continue with this, are we still doing it?
Ryan, great talk. Question, as a result of this project or the other Roboa stuff that you guys have done, have you drilled down on the patients that have had complications and seen what factors might be contributing? So, I mean, we know that SFA puncture is probably the highest one, but other than that, the reason I'm asking this question, we were doing Roboas for peripartum hemorrhage patients in our shop, and what we noticed is we had an unacceptably high complication rate. And we think it's because there's a size discrepancy between small females, vessel diameter, and the Roboa catheter. So I'm curious if you noticed something like that or anything else, that a common theme amongst the complication patients.
Sure, there wasn't really a major common theme between all of them. What I really want to find is the ones that have the major complication, right? The ones I had to either put a stent in or I had to start on anticoagulation or, God forbid, got an amputation. of those patients, what's different about those. We didn't see that more of them were female. However, the literature would think that, especially cardiology and interventional radiology literature, right? It's the female femoral artery is lower. We just had a recent complication. I think we didn't resuscitate the patient. It was female, morbidly obese. And I think that all of those factors led to the major complication we had in that patient because we didn't resuscitate enough, clamp down over the vessel itself, and then thrombose the leg.
All right, thank you very much.
Thanks.
The next abstract listed in the program is going to be presented online in the app, and I would encourage you to watch it. Subclavian vein trauma by Dr. Glaun from Baylor College of Medicine. The next abstract in this room is Dr. Lee from the University of Colorado, presenting "Is the Century Mark the New Gold Standard? The Impact of the Systolic Blood Pressure Activation Criteria on the Need for Trauma Intervention in Elderly Trauma Patients."
All right, good morning. Thank you, Drs. Dent, Zucker, members and guests for this opportunity. We have no disclosures. Appropriate triage of geriatric trauma patients can be challenging. Older patients have altered physiologic response to trauma due to decreased physiologic reserve, underlying comorbidities, and medication effect. These patients do not always exhibit normal stress responses like tachycardia and hypotension, which makes it challenging to identify patients who sustain severe injury. American College of Surgeons Committee on Trauma and CDC jointly published a national trauma triage guideline to identify patients in need of a higher level of care. One of these criteria is regarding trauma patients 65 years or older. A systolic blood pressure less than 110 may indicate a state of shock in these patients. Guideline mandates transporting these patients to a trauma center. However, once patients arrive at a trauma center, the challenge with triage persists as there's a lack of geriatric focused trauma activation protocol. There's paucity of literature on what systolic blood pressure should be used for full trauma activation. COT provides 6 minimum criteria for full trauma activation, none of which are tailored toward geriatric patients. This leads to a wide variation in trauma activation protocol for geriatric population. At 3 participating trauma centers, there's a geriatric specific systolic blood pressure criteria for full trauma activation. Patients 65 years or older presenting with systolic blood pressure less than 110 will receive a highest level trauma activation. The purpose of our study was to evaluate the impact of field systolic blood pressure on the need for trauma intervention rate in geriatric trauma patients. A retrospective review was performed on trauma patients 65 years or older presenting to the ED. Exclusion criteria are listed here. Primary endpoint was NIFT, or need for trauma intervention, and secondary endpoints included in-hospital mortality, hospital length of stay, and ICU length of stay. Need for trauma intervention, or NIFT, consists of 6 criteria listed in this slide. A total of 3,358 patients were included. Patients presenting with a lower field blood pressure were more likely to be younger and have a lower field and ED GCS and a higher shock index. Pre-hospital and hospital heart rate were statistically different among 4 groups. However, this did not appear to be clinically significant as mean heart rate ranged between 75 to 86. A lower field blood pressure was associated with higher injury severity score, higher rate of injury severity score greater than 15, and a NIFT positive rate. Hospital length of stay, ICU length of stay, and mortality were higher in this group as well. Of the patients who were NIFT positive, majority of patients presented with systolic blood pressure greater than 110. Sensitivity for NIFT and ISS greater than 15 increased with increasing the systolic blood pressure threshold at a cost of decreasing specificity. Positive predictive value decreased with minimal improvement in negative predictive value. The area under the ROC curve shows a model's ability to distinguish between positive and negative. 0.5 indicates no discrimination, and 1 means excellent discrimination. The area under the curve for NIFT and ISS greater than 15 decreased with increasing the systolic blood pressure threshold. So in summary, majority of patients who had ISS greater than 15 or were NIFT positive presented with systolic blood pressure greater than 110. Blood pressure threshold of 100 had an improved discrimination compared to the blood pressure threshold of 110. A cutoff of 90 and 100 had a good positive predictive value and discrimination. So using a lower threshold of systolic blood pressure less than 100 could potentially conserve resources as opposed to using a higher blood pressure threshold. The future direction of our study would include cost-benefit analysis to balance between minimizing under triage and optimizing resources. One of the trauma centers had adjusted the trauma activation protocol and decreased the systolic blood pressure threshold to less than 100. And our future study comparing the pre and post adjustment period is currently underway. I'd like to thank Southwestern Surgical Congress for this opportunity again, and I will now take questions.
So I'll just say, this work seems like something that maybe should have been on the main podium and not as a quick shot. This is important information. And because it's a quick shot, you had to go through it very fast. And I'm wondering if you could go back to your slide on the positive and negative predictive values and the sensitivity and specificity. Chris, can you pull up her slides, please? Because ultimately the question is, by lowering the threshold from 110 to 100, how many patients do you miss? And this is, we discussed this at the big podium in the plenary session a day or two ago, where yes, over triage is bad because you utilize resources, but under triage leads to unnecessary death. And so how many patients would you miss did you miss, or are you missing at the trauma center where you now have lowered your blood pressure threshold?
I don't have the exact number, but as you can see, what matters most is we believe is negative predictive value, because when your test is negative, you want to make sure that that patient doesn't need trauma intervention. And with decreasing the blood pressure threshold, the negative predictive value didn't have a significant difference.
Well, I agree. This is very important work, and you're presenting an argument that's opposite of the direction that we've been going, in that we've been raising the blood pressure for our geriatric trauma population to mitigate against unnecessary death. And so this is important to really talk about and elucidate and do more work. I wonder if combining the vitals with mechanism, if that would change anything at all. In other words, if you have high-risk mechanism of injury plus hypotension at systolic less than 110, does that change anything? I think that we're still looking for ways to identify problems before they become life-threatening.
Right.
Very good work.
Yeah, that's a great point. And given, I think, the number of patients, we can potentially look at combining to see if, combining with high mechanism with low blood pressure, does that improve our values in negative predictive values and other values?
Yeah, that's actually a great point. A same level fall with a blood pressure of X versus a motor vehicle pedestrian victim with that same blood pressure, you might see significant difference in need for intervention from a trauma perspective.
Yep.
All right, thank you very much.
Thank you.
And next to the podium, I believe we have Dr. Figueroa for shock index as a mortality predictor, or did I skip? Is that right?
Dr. Werner.
I'm sorry. That's right, Dr. Werner. For shock index is mortality predictor in cirrhotic patients sustaining significant trauma, National Trauma Data Bank analysis. I apologize.
Dr. Figueroa got a residency position.
Okay.
Okay, good morning, everyone. This morning, so my name is Heather Grossman-Werner, and I am going to be presenting our work entitled Shock Index as a Predictor of Mortality in the Cirrhotic Trauma Patient. We have no disclosures. Globally, there are 50 million patients diagnosed with cirrhosis. They have a wide range of systemic abnormalities, but specifically their increased risk of bleeding due to portal hypertension and their underlying coagulopathy result in an increased risk of morbidity and mortality post-traumatic injury. Since Shock Index is an established and validated, easy to use real-time tool to predict mortality in non-cirrhotic trauma patients, We hypothesized that it would have a utility as a predictor in the cirrhotic trauma patient as well. To examine this further, we queried the National Trauma Data Bank from 2010 to 2016 and excluded patients based on unknown admission status, DOAs, and if they were greater than 89 years old. Our final cohort was then stratified based on ICD-9 codes and a comorbidity listed as cirrhosis to generate a cirrhotic all-comers group versus a non-cirrhotic population. Our primary outcome was in-hospital mortality, and we calculated shock index based off of the ED collected heart rate and systolic blood pressure. Our statistics were then completed using ROC comparisons, non-parametric assessment of variance, and logistic regression, controlling for age, injury mechanism, severity, and GCS. Before we compared groups, we first assessed what the definition for a positive shock index screen should be within this cirrhotic to predict mortality. So we can see in the table our ROC analysis for everything from a shock index of less than or equal to 0.3 to greater than or equal to 1.2. We did find that a shock index of greater than or equal to 0.9 had the best predictive value, even over higher shock indexes, at predicting mortality among the cirrhotic population. When we look at the actual ROC curve with the systolic blood pressure, heart rate, and shock index of greater than or equal to 0.9, we can see that using a shock index as the indicator or predictor of mortality has a dramatically higher sensitivity and specificity. Looking at the entire population for in-hospital mortality, we had an overall mortality in our non-cirrhotic patients of 3.3% compared to the 10.1% in all cirrhotics. When we look at shock index of greater than or equal to 0.9 within the non-cirrhotic versus the cirrhotic, we see that that mortality expectedly increases. Where we found the most interesting result was after adjusting for confounding variables, cirrhotic patients had a 3-time increased risk of mortality compared to non-cirrhotic patients with similar injuries and a shock index of greater than 0.9. Our study does have limitations in that this is an NTDB data set, and there are known limitations on the data. Most importantly, there's no granularity to allow for grading of cirrhosis. This data is intended to be hypothesis driving, and we will need to conduct additional trials to demonstrate the reproducibility of this tool in real time. We also were unable to find long-term outcomes due to the data. In conclusion, we believe a shock index of greater than 0.9 may be a useful indicator for early mortality within the cirrhotic trauma population. And that since it does have a better predictor value than systolic blood pressure or heart rate alone, this may be a tool that could be used, especially considering the fact that they have a 3 times greater risk of mortality than similar injured patients without cirrhosis. Thank you for the privilege of the podium and your attention, and I will take any questions.
Dr. Lawless.
Good morning, Lawless from Denver. Shock index, I think, is a very important topic to talk about. Talked about it a couple of years ago on this stage as well, looking at interventions. So picking a number that says that cirrhotic patients have a higher mortality rate based on their shock index. Did you guys look at anything of where should you intervene? What interventions can you do to try to improve that mortality rate? And one thing I think is interesting, I haven't dove into it yet, is the trend in shock index from field to presentation. So are you getting worse or are you getting better? And does that affect the cirrhotics at all?
No, I think absolutely that's definitely the next step. Unfortunately, the National Trauma Data Bank does not provide any pre-hospital data or follow-up data. So we have limitations in that. And even though cirrhosis is a wide spanning topic, unfortunately on a single center level, most of us don't see it at a level that we can make meaningful conclusions. So I think we were discussing some yesterday about how being able to collaborate and get grading for our cirrhotic patients, as well as the pre-hospital interventions and long-term outcomes, would really help us better navigate what changes we can make to resuscitation to hopefully improve survival somewhat or manage our resources.
Thank you.
Thank you.
I think a question that comes to my mind, this is in National Trauma Data Bank data. I suppose that there's no way of really quantifying cirrhosis other than the diagnosis. So next thought that I had was really, when did these patients die? Did we pull that out from the NTDB? Did they die in the first 24 hours? Did they die in 36, 48? When did they die as compared to their cohorts?
So they died more often than the non-cirrhotic patients in both 24-hour mortality and overall in-hospital mortality. The total in-hospital mortality was a little more stark than the 24-hour, but I think the 24-hour, if I remember, was roughly 2.8 as an odds ratio on the adjusted logistic regression. But I found the stark contrast to be the total in-hospital mortality, because those are the patients that didn't die, in the trauma bay. Those are the patients that were on the floor in the ICU that then died a few days later. So,
Right,
but no.
because when they, of course, first come in, nobody knows that they're cirrhotic. That usually
Yes.
gets elucidated either in the operating room or later in the hospital stay. So that, it's always, you always beg the question, well, what do we do? In the first 24 hours, nothing different. I mean, it's game on, resuscitate and so on. But, if they're dying, at hospital day 5, 10, and so on, how do we mitigate that? And do you have any thoughts on that?
I mean, I think our patients who die later in their hospital stay, in the larger set of this data set, we did find a much higher rate of in-hospital complications, surgical site infections, sepsis. So any sort of infectious complication that was listed in the data was greater in the cirrhotic population. So I think we are seeing the additional challenges of caring for these patients long-term, as well as their original traumatic injury and the resultant potential shock. So I think we definitely need better data than just the NTDB, in short.
All right. Thank you very much.
Thank you.
So the last abstract that was assigned to this session is available in the app, and we are done approximately 10 minutes early. So take a short break, stretch your legs, and we'll be back in here at 8 o'clock, I believe, for the next session.